Hello everyone, and welcome to today's webinar, Multiplex Bacterial PCR in Bronchoalveolar Lavage, BAL, Does it Impact Inappropriate Antibiotic Use? I am Jennifer Woods of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by OpGen. To learn more, visit opgen.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. This webinar is educational and thus offers free continuing education credits. Please click on the Continuing Education window at the bottom of your screen to obtain your credits. I'd like to now welcome our speaker, Daiana Stolz, Professor of Respiratory Medicine and leading physician at the University Hospital Basel, University of Basel, Switzerland. Professor Stolz, you may now begin your presentation.
Hello and welcome to this webinar looking at multiplex bacterial PCR in the bronchoalveolar lavage. Does it impact inappropriate antibiotic use? I'm Professor Daiana Stolz. I'm located at the University Hospital Basel in Switzerland and actually transitioning to the University Hospital in Freiburg in Germany. And I'm very happy to be with you today. I'm a pulmonary physician. I treat adult patients, and we've been looking at this methodology since a few years now. So I'm very happy to share with you some views on multiplex bacterial PCR in the bronchoalveolar lavage. You find in this slide my conflicts of interest. I've been supported by several companies, and this specific study has been supported by Curetis, by an unrestricted grant, and it's an investigator-initiated and driven study. So what I would like to do with you in the next 25-30 minutes or so is to look at the challenges that we encounter every day to diagnose lower respiratory tract infections, particularly from the etiologic point of view. Then we would compare upper and lower respiratory tract samples in terms of their diagnostic value. Look at some data on molecular diagnostics in lower respiratory tract infection. And then I would like to present to you some of the latest results we had also presented last week at the European Respiratory Society conference. I don't know if you attended, but this was selected as a late-breaking abstract reporting data on a very recent randomized controlled trial we just finished. So I'll start by stating that the current guidelines looking at community-acquired pneumonia from the American Thoracic Society really highlight the importance of the etiological diagnosis of infection. And they say that gram staining culture is recommended, particularly in patients hospitalized for severe CAP and those with strong risk factors for MRSA and Pseudomonas aeruginosa. So these risk factors are familiar to you, previous infection with the parenteral use of antibiotics in the last 3 months, and this should be looked for because these patients are at risk for gram-negative roads. And also if patients have to be intubated, they strongly recommend to obtain lower respiratory tract samples for examination. So although this is recognized as a really urgent need, it's also recognized that we are not there yet. So we do need more research in this area because we need to develop tools that are rapid, cost-effective, sensitive, and specific to this diagnostic test to identify which are actually organisms that are causing the infection, so that we can really treat in a very effective way. And I believe I will be able to share with you some data that will convince you that actually we do have already some of these tools. We know that the etiological diagnosis of lower respiratory tract infections is a challenge because it is the most important thing to define the prognosis of these patients. If we are able to detect very earlier on in the course of the infection which pathogen is causing the infection, we'll be able to treat this patient accordingly, and the prognosis will be better. So we need to initiate antibiotics at an early stage, knowing what we are treating. Not giving too many antibiotics, too broad spectrum antibiotics because of resistance and costs and side effects, but we need to be right to treat the organism that is causing pneumonia. And this is really a challenge, particularly because conventional microbiology is a really questionable gold standard to determine the presence of infection. We have a really very, very low sensitivity. It goes down to 20% in some studies, particularly if patients are already treated with antibiotics. This decreases the sensitivity of the method. And the other problem is we have to be very patient. We have to wait 2 to 3 days until we get information back from the lab telling us whether the patients have actually a positive culture or not. And only then we can decide how to proceed with the antibiotics. So it's really not ideal, and I don't think we can call conventional microbiology the gold standard currently to establish the etiology of infection. And even if we combine several tests, and this large study published a few years ago in the New England had reported that if you apply conventional microbiology plus a PCR from the upper respiratory tract for viruses, you will be able to detect the etiology of infection in only about 40% of these patients. So in this study, nasopharyngeal and oropharyngeal swabs for viruses have been used. They also use blood cultures, urinary antigen, sputum, and pleural cultures. In very few patients, the bronchoalveolar lavage, and in only 40%, the etiological diagnosis could be made. In this study, they found around 30% viruses and 14% bacteria in patients presenting with respiratory symptoms of the lower airway. So, do we really need lower respiratory tract specimens? We've been learning with the COVID pandemic, unfortunately, that PCR for virus is very effective, but that nasopharyngeal swabs might be actually enough in some patients, and I do believe they are very helpful. But still, if we look carefully, we do learn that respiratory samples from the lower respiratory tract are of special value, particularly in some patient population. So in patients that are immunocompromised, we really might consider to go for sampling in the lower respiratory tract, because in these patients we might have different co-infections, and we have found out that, for example, the recovery of viral PCR is 2 times higher in a lower respiratory tract specimens as compared to patients to nasopharyngeal swabs in patients with severe CAP. So you have a 2 times higher chance to make a diagnosis if you use samples from the lower respiratory tract. We also learned that endotracheal aspirates are more sensitive, that, for example, nostril swabs, if we're looking for influenza, and that the concordance between samples from the upper and lower respiratory tract is far from 100%. It can be as low as 77%, which is significant, particularly if your treatment strategy is will be based on results of this test. Some other studies have talked even about our 40% discrepancy, depending on which respiratory agent we are looking here. So we've learned a lot from viral PCR, and in some patient populations, it's probably not the best idea to stop the examination just after having results of the nasopharyngeal swabs, if you have the feeling the patient has an infection. So we do know that some panels for viral and atypical bacteria are already established, and there is some, we're somehow lagging behind when we talk about molecular assays for bacterial agents. There are not so much data out there looking at their usefulness, but this would be important because if we know which is the bacteria causing the disease, if we know what we're treating here, we might be able to target antibiotic de-escalation and in this way protect the patients from side effects, costs, and also the development of resistance. So we do need to improve our diagnostic yield here, and I do believe that the molecular diagnostic is the way to go. So is it really important? Does it matter? I do think it does, because if we look at the outcomes, they are quite different depending on whether you found a bacteria or virus. And this interesting study suggests that if you find a combination of several agents causing infection, in this case pneumonia, and looking at survival and need for intensive care hospitalization, you see that there is a significant difference. And if we look at the factors that influence hospital survival, we see that next to serum procalcitonin, we also see that the presence of a mixed viral and bacterial infection will indeed influence the chance that you have to leave intensive care in the hospital alive. So I do think it matters to know what the patient has. It can help us to improve treatment. And this is particularly the case, again, in the group of patients with severe disease. I don't think it makes much sense to go and try to find out what young patients that are doing fine outside the hospital with mild symptoms have. Probably their empiric antibiotic therapy is just fine. But if you look at severe disease, and you see on the right-hand side the criteria defining severe infection, severe CAP, and those that are immunocompromised, and this is a large group of patients nowadays, those patients really benefit from etiological diagnosis. Patients with hematological diseases that develop pulmonary infiltrates because of infectious and non-infectious cause. And this patient population, pneumonia is really a killer. And if we don't know we are treating, we're going to have difficulties here. There are some studies suggesting that if you use microbiology, conventional microbiology alone, there is a very low diagnostic yield, also here, 26%. And here we have to consider that because you found a bacteria or a virus, it doesn't mean that nothing else is present. So patients might have multiple etiologies with Pneumocystis carinii, for example, combined with something else, and this is quite relevant for the therapy. So the therapeutic consequences are immediate, and the treatment changes or adaptations might be life-saving. So I think you agree with me that better diagnostic is key here, and that we need tests that are robust to diagnose infections, that provide us information about susceptibility to antimicrobial agents, that are easy to perform, that are rapid, that we can provide information to the physician as soon as possible. And we should question our so-called gold standard with the conventional microbiology. And I think we've seen some mounting data on the literature looking at this test. I selected some studies to share with you. This one looked at a multiplex bacterial PCR in BAL in children, and they've seen that in these 79 children, you found more pathogens in the molecular testing than in culture, and this was a big difference, 83% versus 31%, and the rate of detection was even higher in patients that were immunocompromised and in those that received antibiotics. So patients that were on antibiotics, the chance to find the pathogen of a particular disease was 8 times higher if you use molecular diagnostic instead of conventional microbiology. And so the sensitivity varies across the studies, but I think we can say that most of them support a higher sensitivity of molecular tests. And also some of the tests, for example, the Universal, offers you the opportunity to look at resistance genes that will tell you whether some genes are present that will predict unsensitivity to certain antibiotic therapy. So this other study looked at 65 patients with suspicion of pneumonia at intensive care, and also here the pathogen identification rate was much higher with PCR as compared to conventional microbiology. And here there was no difference in the sensitivity depending on previous use of antibiotic therapy, but they tried to quantify the impact of molecular tests on management. And they came to the conclusion that if they would use the results of molecular testing to decide, they would change antibiotics in up to 20% of this patient. So in a group of patients, these diagnostic tests really have direct influence in the treatment. What is important to note is, as compared to what we are used to see with culture, for which we get a number like 10 in the third or 10 in the fourth or 10 in the sixth potency, for most molecular tests, including Universal, we will have a signal that will be either positive or negative. And for Universal, for example, we know that this for this signal to turn positive, you have to have at least 10 to the fourth if we look at the bacterial count. So the typical bacterial count we have to consider a culture positive is also applied to decide whether Universal test is to be considered positive or negative. And this is important because, as you know, if we believe at the higher sensitivity of molecular testing for the diagnosis, there might be a question of culture detecting organisms, but is this now in the molecular testing, is this a colonization or is this really infection? So for a lower amount of organisms from pathogens that are not necessarily pathogenic, then perhaps there is a question, is this really enough bacteria that will be explaining why the patient is clinically sick, or is just a colonization? And I think it's reassuring to hear that based on the cutoff set, for example, for the Universal test, we can make sure that at least 10 in the fourth potency will be present so that we can call this test positive. So we talked also about the use of bacterial-resistant genes, and this study has looked at this as well, and looked also at the adaptation of antibiotic to microbiology. And I think it's interesting to see that it would be possible to be adapted according to microbiology results in 50% of the cases. But in half of these cases, you would be able to change therapy, to improve therapy already earlier if you would have access to the PCR results. So so far, to make a conclusion or to put together what we know about the resistance genes and how to deal with them, I think we still don't have enough data to say we do not need conventional microbiology. We don't need resistance testing in a conventional way, as we know a resistance testing. But I think there is a growing knowledge in this field, and we definitely have to look for that. We know this from the gene expert, for example, for tuberculosis. It's very helpful and fast to help us decide on how to proceed. So coming now to the universal hospitalized pneumonia panel, it's a panel known in the U.S. as the LRT, so low respiratory tract panel, and it's FDA cleared, so it can be used in patients with respiratory tract infections. It could be CAP, HAP, or VAP. That's what we studied in the last few years in different patient populations, and I will be sharing with you these results. And as you see here, with this test, you have a panel of 21 bacteria that you'll be able to either diagnose or exclude with this test. But you also get this resistance genes, and there are 17 genes that are examined in this panel. And you see here the mutation, but also the gene that you have, but also the which antibiotic will be affected, for which antibiotic you develop resistance if you are able to detect this gene. So I do believe we need more data on this, but it's really reassuring to see that with one test in a very short period of time of a few hours, you were able to get results on the presence or absence of a certain microorganisms, and at the same time to get information about the presence of resistance genes, so genes associated with resistance to the commonly used antibiotics. And the first paper we have published in CHEST now a few years ago looked at the diagnostic value of this method in the bronchoalveolar lavage in a large population of over 500 patients that were heavily immunosuppressed. So those are people that underwent stem cell transplantation, solid organ transplantation. So really, most of them heavily immunosuppressed. The half of them had an infiltrate, and almost 70% were on antibiotics at the time of bronchoscopy. And we compared the results of this universal PCR to conventional microbiology, but also not only cultured, but rather also all analysis needed to differentiate and to detect atypical microorganisms, fungi, a multiplex viral PCR for 18 viruses, and we confirmed the results of this study by using a third diagnostic method, the RNA-16S. So you can see here in these three graphs that show the percentage of positive bacteriology according to the hospitalization time before BAL. So on the left side, you have patients that have been hospitalized before BAL 1 day. In the middle, they have been in the hospital before 3 days before they underwent BAL. And on the right side, 7 days was the mean duration of hospitalization before we performed BAL. And you see that at every time point, 1 day, 3 days, and 7 days, in all patient groups, so those with and without antibiotics, those with and without infiltrates, and those with the combination infiltrates and antibiotics, the percentage, the recovery of a positive bacteriology was higher in the group if you used multiplex PCR, so the universal panel here depicted in fuchsia, as compared to conventional microbiology here depicted in this bluish color. So to every time point you diagnose more bacteria, you have a higher sensitivity if you use a PCR test. And we try to find out what is really the diagnostic yield of multiplex PCR in the BAL, looking at different constellations, because as I told you, I don't believe that conventional microbiology is a very good reference standard. It's called the gold standard, but it's probably more a silver standing also. And here we have looked at patients with and without antibiotics, with positive or negative results of the Gram staining, and those with and without infiltrate. And you see that depending at what you take as the reference standard, you're going to have a different sensitivity and specificity. So if we take the clinical diagnosis as gold standard, we have a sensitivity of 31% and a specificity of 91%. This is really hard, isn't it? Because the clinical standard is also a very poor reference standard to define whether bacteria is present or not. Just for reference, for the conventional methods, the sensitivity was 22% and specificity 98%. So the sensitivity was even lower as compared, if you take the clinical diagnosis as a gold standard for the conventional methods as compared to the PCR. And what we've seen in this study is that the sensitivity and the positive likelihood ratio was higher in, if we looked at gram-negative pathogens. So the Caretis test was more sensitive and had a higher positive likelihood ratio to detect gram-negative pathogens as compared to the gram-positive pathogens. So we went on and designed another investigator-initiated and driven study looking at how this panel, how the Univero panel can really influence or improve the clinical outcomes in patients with suspected LRTA. It was a quasi-experimental pragmatic study that included all patients that underwent bronchoalveolar lavage for suspicion of infection during 12 months in our center. And as again, in one group of patients based on a random 2-to-1 week schedule, we had only the conventional microbiology performed, or the conventional microbiology performed plus the Univero panel. So 2 weeks, we had both examinations. 1 week, we had only the conventional microbiology. So 2 weeks on, 1 week off. And then results of the PCR test, of the Univero PCR test, were provided within 4 hours after bronchoalveolar lavage, but we didn't offer any kind of support or guidance to the attending physician on that. So they got the results, and as they got the results as well from the microbiology, and they were supposed to act as according to the guidelines, to decrease antibiotics, to stop antibiotics, according to what they've learned. And we looked at the primary outcome, which was the use of antibacterial therapy, antibiotic therapy within 30 days after bronchoscopy. So we had a group that had both examinations and one group that had only the conventional microbiology. We didn't provide any guidance. Physicians had access to the PCR results in one of these groups, and we looked at what happened after 30 days. And this was quite interesting. We had over 600 of patients, half of them immunocompromised, and about a half were on antibiotics after bronchoalveolar lavage. The other group had already before being treated with antibiotics. They received antibiotics for 11 days. Mortality was around 5%, so it was a population with relevant disease. And we've seen that the Univero panel has detected bacteria much more commonly than conventional culture. So there were 50% more bacteria detected using the molecular test as compared to conventional culture. But interestingly, if we look at the length of antibiotic use, the number of antibiotics prescribed, and the length of hospital stay, there was no difference between the two groups. Okay, perhaps it tended to be a bit shorter, the use of antibiotics in the group that had also PCR results, but this was not statistically significant. So it was a bit disappointing to see that although we found more bacteria and we knew what we were treating, it didn't really make a big difference because people didn't change the antibiotics, or they decreased, they stopped a bit earlier, but not as much as we would expect. So we thought, why is that? And we came to the next study, which is the new data I would like to discuss with you today. That was around the fact that we know that antibiotic stewardship is quite a challenging issue, isn't it? We know that we feel uncomfortable in stopping antibiotics if we do not know what is going on. But we need, in this case, an objective measure of infection, and we need to know what is going on. So the question in this study was, if we combine the result of the multiplex bacterial PCR with a recommendation based on this result to the physicians, can we then improve the treatment? Can we decrease the use of inappropriate antibiotic therapy in these patients? So this is a big question, isn't it? This is the question, can you really influence therapy? Can we decrease the use of inappropriate antibiotic therapy by providing people results of a molecular diagnostic test coupled with or together with, embedded with a recommendation telling them exactly what to do? So if we found this bacterium, that's what you have to do with the antibiotic therapy. And that's the question we wanted to answer in this study. So what we did here was, again, an investigator-initiated and driven, randomized, controlled, multi-center trial. Our primary endpoint was the duration of inappropriate antibiotic therapy. And we focused on adult patients with suspicion of pneumonia and a clinical indication for bronchoscopy. And they also have to have a risk for infection with gram-negative bacteria. So we were focusing on the sickest group of patients, this patient group that we've learned from the recent CAP guidelines should be treated with gram-negative coverage. This is a group of patients that has risk factors, as we discussed before, and this is the group of patients that we were focusing here, taking benefit from the fact that the universal panel seemed to be particularly helpful in detecting gram-negative roads. We excluded everybody that was neutropenic with severe GVHD, pregnant women, and you see on the left side of the slide the study design. We have screened 740 patients. From those, 217 were eligible. And from these 208 that could be randomized, we had 100 that been allocated to the intervention group and 108 that have been allocated to the control group. So what does it mean? The intervention group was the group of patients that received bronchoscopy and got, on top of the microbiological conventional diagnosis, a determination of the presence of bacteria using the universal panel. And the control group received bronchoscopy and have the bronchoalveolar lavage analyzed solely by conventional microbiology examination. So that was the design of the study. Within 4 hours after bronchoscopy, we could share with the attending physician results of the PCR of the BAL and tell them we found gram-negative roads. That's the way we would adapt the antibiotic therapy, or we didn't find any gram-negative roads. And it's important to make sure that we understand that we didn't recommend stopping all therapy, but we recommend de-escalating from usually piperacillin tazobac to, for example, amoxicillin caveolin acid. So those are the patient characteristics in this group. Those were patients around 65-year-old, and you see that they had several comorbidities, immunosuppression again present in around 50% of the cases, with lots of respiratory symptoms, an increase in CAP to 140, so quite high infect signs in the lab, and also procalcitonin of 0.68 and a PSI score of 32. Around 70% of the patients were on antibiotics at the time of bronchoscopy for around 34 hours, and we have looked at almost 400 different antibiotic regimens that they were receiving. So to the primary endpoint of the study, this was the duration of inappropriate antibiotic therapy. And you see we have analyzed the administered inappropriate antibiotic therapy and the prescribed inappropriate antibiotic therapy. So that's what you see on the left-hand side and the right-hand side. And indeed, the use of the universal PCR panel could decrease the use of inappropriate antibiotic therapy from 86 hours in the control group to 47 hours in the PCR group, which is highly significant. This means it's a reduction of the inappropriate antibiotic therapy by almost 50%, and the whole duration of the antibiotic therapy could reduce by 1/4. So I think really quite significant results, a very low p-value suggesting that this effect is quite robust. Then we also looked at freedom from inappropriate antibiotic therapy, and I must share that we have as a predefined condition for definition for inappropriate antibiotic therapy, which also include the fact that the therapy should be for at a maximum of 7 days after the BAL. So if somebody has been treated longer than 7 days with an antibiotic, it was considered to be inappropriate because it's too long. So in this chart, you only see what is happening in the first 7 days. After that, everybody would have an inappropriate antibiotic therapy based on predefined criteria and analyzed by a committee that included someone from internal medicine, someone from infectious diseases, and an ophthalmologist. But you see here what happened in the first 7 days, and you see the freedom from antibiotic therapy, which was significantly higher in the group that have been examined by the universal PCR panel. Indeed, the probability of being free from inappropriate antibiotic therapy was 3 times higher in the patient group that was examined with the PCR. And here, I must say, also to make sure that, okay, we are decreasing the amount of antibiotics, we are using less broad spectrum antibiotics here, so really more appropriate antibiotic therapy, less inappropriate, but at the cost that the patients are having a poor outcome. This is not the case. So we look very carefully at several criteria, looking, for example, at the time to clinical stability that has been evaluated daily, and you see very, very similar curves here. So we had 91 or 92% of the patients reaching clinical stability of being discharged over time. The time to clinical stability or discharge was exactly the same in both groups. Also, the length of hospital stay was the same. Intensive care admission was the same, and the mortality at 30 days was also the same for our group. So it's not only that you are decreasing the antibiotics, you are giving appropriate antibiotics instead of inappropriate, but you are doing this without any costs. The safety of this approach seemed to be quite good, as demonstrated by this data. If we look at the diagnostic performance, we found bacterial agents in around 1/5 of the patients. Even if we look with molecular diagnostics, it's not that easy, confirmed by this study. We found more gram-negative roads in the BAL using the PCR as compared to culture. as expected, and the sensitivity and specificity as compared to the conventional microbiology was around 56 and 87%. Again, we already discussed that these figures are difficult because of the lack of a real gold standard. So I think based on the data we've discussed today, I think we can say that if you incorporate results of the Univero panel, so a multiplex bacterial PCR of the bronchoalveolar lavage into an antibiotic stewardship approach that should be going on everywhere anyway, it makes sense, it is efficient, it's safe, and it really decreases time on inappropriate antibiotic therapy, particularly if we look at the population we examine here, hospitalized patients with pneumonia at risk for gram-negative roads. And for sure, there are other questions that have to be addressed in the future. The cost of this approach, I believe we will reduce significantly the cost because patients will receive less antibiotics, have less side effects, and probably go home earlier. But we will need larger studies to confirm these findings. So, take-home messages, I would say that the main advantage of a bacterial multiplex PCR relies in its speed. I mean, it's a fast examination. You have results very early, and you are able to adapt antibiotic therapy very early. It has higher sensitivity than conventional methods. If we talk about the Univero, if we look about specifically if we focus on gram-negative roads, I think we can say that. And we do not have any data supporting the use of this technology alone. We cannot refrain from performing conventional microbiology, and we cannot also not say that we do not need antibiotic stewardship. It's very important. But if we combine antibiotic stewardship with the PCR results, then we have a clear gain for our patients. We can reduce the duration of inappropriate antibiotic therapy, and I think this might have major consequences for patients and institutions. So with that, I will stop here. I'll thank you for your attention, and I'll be very happy to take your questions and discuss how do you see these results, how you can apply this technology to your clinical work. Thank you very much.
Thank you, Professor Stolz, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you would like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many of your questions as we have time for. Let's get started. Our first question is, which gram-negative rods were most prevalent in your study?
Yeah, so thank you for the question, and I think it's an important information that I didn't share with you. But I think the ones we've seen most commonly were the ones that we expected: Pseudomonas aeruginosa and Haemophilus influenzae. I must say, Switzerland, especially the north of Switzerland, is blessed by have been very restrictive with the use of broad-spectrum antibiotics. We do not have highly resistant gram-negative roads in our ICUs so far. So we don't see things like we used to see in the US with really a lot of very resistant gram-negative bacteria, but we do see the same spectrum of bacteria in our care here.
Thank you, Professor Stolz. The next question is, based on the impact that Univero made, which were reduction in the use of inappropriate antibiotic therapy by 45.1%, shortened inappropriate antibiotic therapy by 39 hours, and 3 times higher probability of avoiding inappropriate antibiotic therapy, etc., what is the cost savings impact?
Yeah, that's a good question. The study didn't focus on the costs or the cost savings that this technology created, but I think it's a sensible question to ask. I believe there are two different important parts of the information here. The one is how much money we can save really within one hospitalization by decreasing the exposure to antibiotics and probably side effects. The other one is also the impact that it has in a broader view, meaning, what happens to the development of resistance within a hospital as such. So I think that's an important question to explore. I cannot offer you an answer right now, but I'm sure it makes sense to go after that, and I'm sure that the benefits won't be only financial for one particular patient, but will also transfer into savings for an institution.
Thank you, Professor Stolz. I'd like to remind the audience that if you would like to ask a question, please do so now. Click on the Ask a Question box and then type in your question, click Send. We have one more question in the queue here. Is the Univero system easy to use? Was it run in the lab or was it run by the medical staff during your study?
Yeah, well, we organized the study in a way that we had the Univero system located next to the bronchoscopy suite. It's quite a small system, so you find place almost everywhere to place it, and it's actually quite easy to use. The test was performed by our endoscopy staff, so immediately after finishing the bronchoalveolar lavage and sending the patient back to the station, they prepared the probe for testing, and the bronchoalveolar fluid has been placed in the machine. It's really quite intuitive, and after appropriate training, I think everybody is able to deal with it. I think it has a potential to be a point of care test, and it saves for sure time. I think it's also interesting that we've seen that for a proportion of patients, physicians were aware that they would get the result within 4 hours, so they kind of waited to get the result of the PCR to start antibiotic therapy, because they thought, okay, 4 hours, it's a time span that it's okay to wait. I can for sure not wait 1 or 2 days, but 4 hours it's okay. So we've seen a lot of patients that start receiving appropriate antibiotic therapy to begin with. And I think this time aspect is quite important because it really decreases the exposure to the wrong drugs. It's much more difficult in the hospital to change a therapy that has been already established than to start to begin with the right therapy.
Thank you again, Professor Stolz. Looks like we have no other questions in the queue. Do you have any final comments for our audience before we go?
Well, I think this is an extremely interesting field to explore, and I advise everyone that is involved in the treatment of patients with severe pulmonary disease to consider this technology, as we really have to care about decreasing antibiotic resistance and making sure that we are treating the right patient with the right drug. It has been a major development for our hospital. We do have a lot of stem cell transplant patients, so we're very happy to count on a very fast test that is reliable and help us to treat patients in a better way.
Thank you again, Professor Daiana Stolz, for your time today and for your important research. We would also like to thank LabRoots and our sponsor, OpGen, for underwriting today's educational webcast.